namely trigeminal neuralgia, which is a condition I hope many of you maybe already know about, but I thought I'd just introduce you to some of this, to this condition. It's a condition and disease process that I sort of developed this subspecialty interest in over the 7 years that I was working up at Tufts, and I thought I'd just kind of share some information about it. So what trigeminal neuralgia is in its classic form, paroxysmal, severe lancinating facial pain. And I'm going to kind of several times throughout the talk just repeat the definition of what this is, because you'll come to learn that to diagnose trigeminal neuralgia, really the most important thing is a good history and just characterizing the nature of the pain. But in the patient's own descriptions, it's the most horrific kind of electric-like pain, typically on one side of the face that patients can experience. The pain can involve really any part of the face, again, on just one side of the face. Oftentimes patients can just have dental pain as well, so sometimes patients are totally misdiagnosed with dental pathology. Pain is typically sudden in onset, and the pain, again, is sharp, electric-like, and not usually associated with any numbness of the face. In the traditional definition, patients who have trigeminal neuralgia don't have these other characteristics, namely the pain is not constant, it's not burning or throbbing, and it doesn't really ache. It's really just sudden onset, acute, unexplained, electric-like pain in the face. And just to give you an idea of how severe this pain is, when people look at the different kinds of pain conditions that patients have, this is generally thought to be the most painful condition that humans can experience. In fact, patients have committed suicide due to the severity and nature of this kind of pain. There are some things that can make the pain worse. Typically, pain is worse when patients are under stress. Also, patients typically describe trigger points, meaning just very, very light stimulation of that side of the face can elicit pain. In fact, patients often say that just by gently scratching the face, shaving, the fear that these patients live in, because they just can't really carry out their normal activities of daily life, to the point where if it becomes really severe, they essentially become recluses and just draw away from society. Trigeminal neuralgia tends to affect up to 5 people per 100,000. There are up to 50,000 new cases diagnosed in the US alone per year. And typically women are affected more than men. And this is not a genetic disease in that it's not typically handed down through generations. If you look at what are the typical ages that patients present, this is really a disease of the Middle Ages, affecting people typically from their 40s to 70s, with a median age of presentation around their mid-50s. As far as the natural history of the disease process, the most frustrating thing probably to patients is that there's no rhyme or reason to when or why their pain comes on. And oftentimes there are cycles of pain where all of a sudden the pain will come on and it'll affect them really horrifically to the point where they can't function for maybe days to weeks, even sometimes months at a time, and then for no reason the pain will go away. And they'll feel totally normal, be able to resume their normal lifestyles, and then typically within weeks to months to years, the pain will come back again without, again, any explanation. What usually is the case, though, is that as time goes on, periods of remission become shorter and the pain becomes worse. Oftentimes, patients just deal with this pain for some time and have no diagnosis, or in fact, the majority of patients are given some sort of inaccurate diagnosis. And in fact, many of these patients, because they complain of dental pain, end up seeing a dentist. And a majority of patients, before they're given a proper diagnosis, undergo unindicated dental procedures such as teeth extraction, bridge placement, you name it, before finally the dentist gives up and says, oh, well, I don't think you actually have dental pathology, and then they end up finding an internist or a neurologist who then makes the proper diagnosis of trigeminal neuralgia. The good thing is that trigeminal neuralgia typically is very responsive to the treatments that we have, and I'll go over those in just a bit. But medications typically initially are very, very effective. And unlike a lot of other pain syndromes, narcotics are not really effective for this specific pain entity. Rather, anti-epileptics tend to be the treatments of choice. Just to give you a little reminder of the anatomy, the trigeminal nerve has 3 distributions: the ophthalmic, or V1, maxillary V2, as well as the mandibular in V3. And pain can really involve any one or multiple distributions of one side of the trigeminal nerve in the face. Pain, again, is typically isolated to one side of the face and usually involves only 1 to 2 branches, not usually the entire side of the face. In fact, if you look at the distribution of pain, most patients complain of pain typically in the V2 and V3 distribution. So in the cheek, upper lip, maybe in the jaw, lower lip, and then also in the mouth and the dentition. Those are the most common distributions for this kind of electric lancinating pain. Again, just to go over again what the typical presentation is: paroxysmal, severe facial or dental pain. Now, there's a differential diagnosis for this kind of pain. There are pain syndromes that can come on from injury to the trigeminal nerve, either accidental trauma to the trigeminal nerve, or sometimes in patients who have trigeminal neuralgia, one of the treatments is actually to deaden the nerve and to cause deafferentiation of the nerve, and that alone can cause a different kind of pain syndrome. There are also atypical types of trigeminal neuralgia, those that involve more burning or throbbing pain or pain that's a little more constant. One thing to remember is that atypical trigeminal neuralgia, the kind of trigeminal neuralgia that has burning and throbbing, is not the same as atypical facial pain. Atypical facial pain, if you hear that, that's really like a bucket term for patients who have more of a somatoform type of pain that really doesn't seem to have a very good physiologic cause to it. The key to treating patients with trigeminal neuralgia is to make an accurate diagnosis. One, as a treating physician, has to really differentiate trigeminal neuralgia and weed out all the other diagnoses of possible other craniofacial pain disorders when you're making the proper diagnosis. And once you can find the patient that has trigeminal neuralgia and make the accurate diagnosis, you'll find that trigeminal neuralgia really is treatable, and that the modalities that we have to treat trigeminal neuralgia really are specific for trigeminal neuralgia and not really effective for other kinds of facial pain syndromes. Just some of the diagnostic differentials as far as craniofacial pain syndromes, you can see there are a lot. Patients can have headaches, eye problems, ENT problems, temporomandibular disorders. All of these things can sometimes look and present somewhat like trigeminal neuralgia, and this is where a good history really will make the key in making the proper diagnosis in finding someone with trigeminal neuralgia. Again, there are other types of facial pain syndromes specifically that really can mimic trigeminal neuralgia, such as trigeminal injury. Patients with MS, a high percentage of patients with MS will actually also present with facial pain. That's typically due to a demyelinating plaque within the brainstem. That's otherwise known as symptomatic trigeminal neuralgia. Patients who've had post-herpetic neuralgia involving the face can also have a pain syndrome that's typically preceded by a herpetic rash in a specific distribution of the trigeminal nerve. And then there's also atypical facial pain. So trigeminal neuralgia needs to be differentiated from all these other types of facial pain syndromes. The typical exam of a patient who has trigeminal neuralgia when they're having an acute attack is one of which someone really guards the face because they don't want any stimulation, even light stimulation, accidentally affecting that side of the face. Patients guard their face. They're usually very still. They're withdrawn. They don't want to talk. They may have not really kept up with their normal hygiene because they just haven't been able to brush their teeth or do things normally because of the fear they live in with this kind of pain. If you do examine them, there's essentially no motor or sensory deficit that you can identify in these patients. Essentially, they look neurologically normal. But again, these patients are just living in severe pain and fear. So again, the key to making the diagnosis is a good history. And then following that, once you think you've made the proper diagnosis, you have to get imaging in the brain. And that imaging is primarily not to necessarily look for any key pathognomonic finding on MRI for trigeminal neuralgia, but it's basically to rule out a mass or a lesion that could otherwise explain why the patients have pain. Occasionally, you do see trigeminal nerve distortion or vascular compression, and I'll get into that a little bit more, but vascular compression is one sign of patients who do have trigeminal neuralgia. Another key to making the proper diagnosis is that patients with trigeminal neuralgia typically have an incredible response, initial response to anti-epileptic medications. And in fact, their response can be diagnostic of whether or not they really have trigeminal neuralgia. In other words, if you have someone who has trigeminal neuralgia, or you think, and you put them on an anti-seizure medication and they don't respond, after several trials of different anti-seizure medications, you may have to rethink your diagnosis of whether or not this is really trigeminal neuralgia. So as far as, again, ruling out mass lesions that can explain why patients have pain, and this is the reason why you get imaging such as an MRI of the brain, the most common tumors that can lead to facial pain are those that are located in the cerebellopontine angle, such as vestibular schwannomas or meningiomas. And again, occasionally on MRI, you can also identify demyelinating plaques such as in MS that affect the brainstem that can lead to facial pain. In fact, one large series from the Mayo Clinic that looked at all the patients with so-called trigeminal neuralgia, they found that up to almost 10% of patients actually had tumors that were the source of their pain. Now, what they found is that, in retrospect, even though all these patients were diagnosed with trigeminal neuralgia-like pain, and 10% of them had tumors, those who actually had tumors had other neurologic dysfunction that is not really, again, pathognomonic for trigeminal neuralgia. But it just, again, lends to the idea that you need to rule out a tumor or an existing mass lesion that's the source of the patient's pain. So again, once you've ruled out a mass lesion and you have a patient who has the typical symptoms of paroxysmal pain that's unilateral, restricted to really only one or usually two distributions of the trigeminal nerve with trigger areas and no neurologic deficit, meaning no motor or sensory deficit, then you can pretty much feel rest assured that you've made a diagnosis of trigeminal neuralgia. And there's a whole algorithm with how to go about treating patients with this kind of pain. And typically the first line of treatment is anti-seizure medications once you've found that they have a normal MRI and not a mass lesion. And then depending on how they respond to those anti-seizure medications will ultimately determine whether or not you need to progress beyond medical treatment into the surgical or radiosurgical procedures. So I thought I'd talk just a little bit about the medications that you use initially. Again, they're anti-epileptics. Typically you start out with one agent, and usually, again, the hallmark of trigeminal neuralgia is that these patients are extremely responsive to the initial course of anti-epileptic medications, to the point where it's almost like a miracle drug. Within days of trying this and starting this medication, the patient's pain really improves dramatically. Typically, you keep them on that monotherapy until their pain has been really well controlled and they don't have any bouts of pain, and then you can try to wean it. Ultimately, the natural history, though, is that the pain comes back. Patients have to be put back under these medications, and ultimately they develop tolerance to these medications, in which case then oftentimes you have to add second or third agents, and then ultimately become less responsive to even those combination therapies. The medications that are used, the most common is Tegretol, and again, the response that patients have to Tegretol is almost diagnostic. Like if they don't respond to Tegretol or oxcarbazepine, then you have to sort of rethink your diagnosis. So these are the first line treatments, and then we go down the line and try other medications if and when patients become tolerant to these first line medications. Now, once and when patients become less sensitive or less responsive to medications, that's when we start to think about surgical treatments. And in general, the surgical treatments can be divided up into those that are the percutaneous techniques, in other words, needle techniques to affect the trigeminal nerve by placing a needle through the face and changing the function of the nerve, versus the open surgical techniques that really involve exploring the nerve and manipulating the nerve to improve the pain. The percutaneous techniques are in general those that involve rhizotomies, in other words, deadening or killing specific nerve rootlets within the trigeminal nerve, either with radiofrequency or with neurotoxic agents or with balloon compression. Open surgical techniques, which involve a craniotomy, involve exploring the nerve and, again, removing that vascular compression that I'll show you, or even maybe just performing an open craniotomy to just cut a part of the nerve. As far as the anatomy, again, the trigeminal nerve leaves the ventrolateral pons, travels through the paramesencephalic cistern into Meckel's cave, where it becomes the Caesarean ganglion and then divides into the three branches of the trigeminal nerve. The percutaneous techniques rely upon placing a needle percutaneously through the cheek, usually under fluoroscopic guidance, through the foraminal valley where V3 goes, and then landing the needle into the Glycerol ganglion. And then with the patient in a sort of twilight, semi-awake state, testing the nerve with a little electrical stimulation to make sure you're in the right part of the trigeminal ganglion before you actually affect the nerve. So this is just a little cartoon of what we do. Place a needle percutaneously through the cheek into the Glycerol ganglion. In the radiofrequency rhizotomy, which is the percutaneous technique that I personally tend to favor, you can actually heat up this tip of the nerve until you create a small lesion within typically one or two branches of the trigeminal nerve, the one that's the most affected. You wake the patient up, and then you ask them, how's your pain? Or you actually even also test that side of the face. And then you keep burning the nerve essentially until you get an adequate degree of numbness. And essentially the degree of numbness you give them correlates with how much pain relief you'll give them. And so this is a totally percutaneous, semi-awake procedure that does not require general anesthesia. With the neurotoxic rhizotomies, it's a similar idea with the needle placed, but instead of a radiofrequency ablation of the nerve, a neurotoxic element such as glycerol or phenol are placed into Meckel's cave and allowed to then destroy part of the nerve. Or in balloon compression, a deflated balloon is placed through the needle into the Glycerol ganglion, inflated, and then compression of the nerve actually deadens part of the nerve and can bring about pain relief. Generally, these results are excellent. These percutaneous techniques are effective for patients who are having an acute attack of trigeminal neuralgia. In fact, again, some patients are suffering from so much pain they do get admitted as inpatients. And this is a totally valid indicated procedure for patients who are having such an acute bout of pain. But again, when you deaden the nerve like this, you're essentially replacing the pain with numbness. Now, most patients who have this degree of pain, they don't complain that the numbness is really bothersome. In fact, most any one of them would replace the pain that they have with the degree of numbness that is incurred. And I'm talking about numbness, not paralysis. So it's nothing like a Bell's palsy or any kind of noticeable deficiency of how the face moves. The results from one of the largest series from the University of Cincinnati, which really mimics my own results, is that in almost all patients following these percutaneous techniques, the patient's pain is relieved. The degree of numbness they have is in proportion to how much pain relief they get. And there are only a small percentage of patients that have some sort of unusual feelings or dysesthesias following that procedure. And essentially there's minimal to no mortality following this kind of outpatient percutaneous procedure. The long-term results are also good, with up to only 20% pain recurrence really at 9 years following these kind of procedures. And this procedure can be repeated if the pain does come back. And so this patient had an excellent result. She woke up totally pain-free. She actually had been admitted for such severe pain, but woke up totally pain-free and has remained so for years. And so, this microvascular decompression technique is really immediately effective for patients with trigeminal neuralgia. The advantage over the percutaneous technique is that it doesn't involve any destruction of the nerve, so there's no numbness that's incurred. It does, however, require, again, open surgery, requires general anesthesia, inpatient hospitalization, and the results, my own personal results, mimic those of the University of Pittsburgh, where they have a large series that have shown that the vast majority of patients have excellent results with essentially no facial numbness, very, very few patients who have any kind of dysesthesias of the face following microvascular decompression. And the long-term results are also excellent, with more than 70% of patients having long-term excellent pain relief at 10 years following this procedure. However, this is a major surgical procedure that requires craniotomy, general anesthesia, so there is a small but ever-present population of patients who undergo this procedure that are going to have some sort of complication or even have more mortality. 30% recurrence at 10 years. At 10 years, yeah. So if you had to compare the surgical procedures, the advantages of the percutaneous procedures are that almost universally patients have excellent outcomes. The long-term recurrence is relatively low, even at 9 years. There's minimal mortality, and it's a relatively inexpensive procedure that's an ambulatory outpatient procedure. The advantages of the microvascular decompression are that, again, almost all patients have excellent pain relief following this kind of procedure. And on top of that, there's no destruction of the trigeminal nerve, and so there's no numbness that's incurred. The disadvantages of each of these procedures is that, again, with the percutaneous techniques, you're incurring facial numbness, and in fact, if you need to repeat the procedure over and over, that's when you start to potentially cause deafferentiation pain, in other words, anesthesia dolorosa, that can lead to a whole nother pain syndrome. The disadvantages of microvascular decompression are that there is a small but ever-present risk of major morbidity, mortality. It doesn't necessitate general anesthesia, is an inpatient procedure, and is clearly a much more involved procedure than the percutaneous technique. So I thought I'd finish up by talking about sort of one of the later technological developments in treating trigeminal neuralgia, namely gamma knife radiosurgery. Now, some of you may have kind of heard about gamma knife radiosurgery or radiosurgery, but may not know necessarily what it is. Well, what radiosurgery is, in the words of this gentleman pictured here, who's Lars Lexell, considered the father of modern-day radiosurgery. In his words, radiosurgery is the delivery of a single high dose of radiation to a small but critically located intracranial volume through the intact skull. In other words, through a single outpatient treatment, a very high dose of radiation is focused on a very small volume within the head. And we can usually use this kind of radiosurgical one-dose treatment to treat things such as tumors or vascular malformations. But what we've also found is that it's extremely effective also for trigeminal neuralgia, when we can target the trigeminal nerve with this kind of high-dose radiation. The theory behind gamma knife radiosurgery is that we can basically place a patient's head into a radiation vault that basically houses over 200 radioactive cobalt beams that are all centered on a specific point. And if you can imagine all of these hundreds of beams centering on a single point, that essentially right where they converge is a very single point dose of extremely high dose radiation, whereas all the surrounding tissues in the brain receive essentially no radiation, since they're only seeing maybe 1 or 2 beams of radiation at the most. And so if you can basically place a patient's head precisely within the center of this radiation field and make sure that the tumor, or in our case the trigeminal nerve, is sitting right at this sphere, you can really pinpoint where you want that radiation to go. The way gamma knife radiosurgery is done is that we start out the day by placing a patient's head into a frame. What this frame does is allow excellent fixation so that there's no movement of the patient's head during this radiation. As you can imagine, this is very high dose radiation, so we don't want this radiation to spill out even over less than half a millimeter. The other thing is that it does is with this frame, it sets up a Cartesian coordinate system where we now know within XYZ coordinates exactly where the volume is that we're trying to treat. The patient then undergoes an MRI with that frame in place, and then that MRI is imported to treatment planning software, as you can see here. And in this case, this is what our treatment planning software looks like, in this case a tumor. And we can essentially in 3 dimensions mark out very, very precisely what that tumor volume is. And in our case, in trigeminal neuralgia, it's very simple to identify the trigeminal nerve. But you can imagine, even if you have a complex 3-dimensional tumor volume, regardless of how complex that volume is, essentially you can load up that volume with little spheres of radiation until you basically get this very complex conformal plan of high-dose radiation filling up that complex tumor volume, just by making small movements of the patient's head within that vault of radiation. The patient then undergoes treatment, and this is what it looks like when the patient actually goes in with the head fixated into this collimator before they go into the radioactive vault. And this is where the beauty of radiosurgery is that typically when patients present with symptoms or then diagnosed, say somebody with trigeminal neuralgia, say they then underwent an open microvascular decompression. Well, after that open microvascular decompression and craniotomy, they typically have to spend at least 1 or 2 days in an ICU recovering, several more days on a regular hospital floor recovering until they're discharged. And then even after discharge, there's several weeks of convalescence and recovery. This is totally different than radiosurgery, where after diagnosis, they come in for that single outpatient radiation treatment, go home that same day, and essentially there's no recovery. There's no side effects the patients really experience. There's really only the upside of eventually having pain relief with trigeminal neuralgia. Now, out of the hundreds of patients that I treated with gamma knife radiosurgery for trigeminal neuralgia, we look back at all the patients that we treated who had at least 3 years of follow-up. And this is, over a 7-year period. And what we found is that initially, following the Gamma Knife treatment, 80% of patients had excellent pain relief. And then as we followed these patients out, even at 4 years, up to 2/3 of patients still had excellent pain results. In other words, following the single outpatient Gamma Knife radiation treatment, without surgery, without really any kind of needle destruction of the nerve, patients had excellent pain relief. So this is my last slide. I'll just finish here. Hopefully you've learned a little something about trigeminal neuralgia. If you run across or hear of someone who may have some facial or dental pain, maybe the idea of them possibly having trigeminal neuralgia will come up. I hope you've learned that a good history and differentiating patients with this kind of pain from others is crucial in making the diagnosis. Accurate diagnosis really is key. And then once the diagnosis is secured, we really do have a lot of effective treatment modalities, namely medications, surgery, as well as radiosurgery. So I'll just stop there and see if anybody has any questions.